Rising Star Contest Part 2. Today's topic is mainly arthroscopy, and we have the young and dynamic rising stars of this year. To introduce this program, I will hand over to the creator and the provisionary of this program, BOS Immediate Past President, Dr. Sanjay Dar.
Good evening and welcome everyone. This is I think the third episode of the second episode, season 2 maybe. So this is, as I'm sure you know all the rules, and this today is the arthroscopy session. We have with us Dr. Ashish Fadnis, the Secretary of Bombay Orthopaedic Society, and we have judges Dr. Sandeep Deore. And I welcome you all for this edition, and I wish you all the best for this. Dr. Nikhil is there, I think, as the judge. So I wish you all the best for a great stint. I'm sure we all learn from this experience, and wishing you all the best for your future endeavors. Back to Neeraj.
Ashish, with this I hand over to Ashish to say a few words. He had a very good impression of the first episode of the program, which was on arthroplasty. Let's hope all these 5 speakers today carry forward the same. Yes, Ashish.
Yeah, welcome everyone, and I'll welcome Dr. Nikhil Agarwal and Dr. Sandeep Deore, who have graciously agreed to judge today's session. So, as you know, I mean, Dhar sir had come up with this idea, which was a very innovative one, to give the youngsters sort of a platform to speak about certain aspects and topics in their specialties. So today we are going to hear from the 4 of you. Unfortunately, Dr. Darshan is not with us today, but Dr. Mitali, Dr. Nihar, Dr. Vasav, and Dr. Dattatreya will be speaking to us, and the topics have been allocated to you. This is a test of how you present and your understanding of the topic. And we understand that you're speaking more from sort of what you have read and not so as much from your experience, but the judges would take that into account. And I wish you all the best, and have a glitch-free presentation and a good presentation. Okay. So Sandeep, you can start. We can, Mitali, you can start sharing the screen as you are the first speaker. So Mitali is going to talk on outcomes of single bundle versus double bundle ACL reconstruction, a review of current literature.
Is my screen visible, sir?
Yeah, we can go to the full screen presentation. Yeah. Good.
Good evening, everyone. I'm Dr. Mitali Mokashi, a senior resident at St. G.S. Medical College and King Edward Memorial Hospital, Mumbai. I would like to talk about the outcomes of single bundle versus double bundle ACL reconstruction as a review of current literature. So the evolution of the ACL reconstruction started in 1960 with Hay Grooves doing the first open ACL reconstruction using the iliotibial band. In 1934, Galeazzi followed it up with the first ever semitendinosus graft used for open ACL reconstruction. Tandy et al. In 1980 pioneered the first arthroscopic ACL reconstruction using carbon fiber allograft. The first double bundle open ACL reconstruction was done in 1982 by Mott et al. In 2000, Yasuda and Fu pioneered the arthroscopic double bundle ACL reconstruction. Initially, non-anatomical tunnels were used with transtibial drill. Then came over the anatomical single bundle anterior cruciate ligament reconstruction, which was followed by the double bundle. Now, the basis of this double bundle reconstruction was the complex anatomy of the anterior cruciate ligament. The anterior cruciate ligament has an anteromedial bundle which arises from the proximal aspect of the femoral attachment and attaches onto the anterior aspect of the tibia. It resists anterior tibial translation. The posterolateral bundle originates at a distal part in the femoral attachment and attaches posteriorly on the tibial attachment with some fibers which may go to the posterior horn of the lateral meniscus. It resists rotational translation. Coming to the methodology of comparing single and double bundle ACL reconstruction, electronic database was used with a filter of last 15 years. Level of evidence 1 or 2 randomized control trials, systematic reviews, and meta-analysis were included, with high citation index being preferred. The anatomical ACL reconstruction single bundle lies on the basis of making a femoral tunnel in the center of the femoral attachment of the ACL through the anteromedial portal and a tibial drilling via outside-in technique at the center of the tibial footplate. The anatomical double bundle ACL reconstruction proceeds with femoral anteromedial tunnel being drilled through an accessory anteromedial portal. Then the tibial, anteromedial, and posterolateral tunnels are drilled at 55 degrees and 45 degrees respectively. The femoral posterolateral tunnel is created, grafts are passed, the anteromedial graft is tightened in 45 degrees of flexion, and posterolateral is secured in full extension. Coming to the outcomes of single bundle versus double bundle reconstruction in ACL, the outcomes can be compared on the basis of mechanical stability, functional outcome, and on the basis of the complication rate. With respect to the mechanical stability, in 2022, Ikuta et al. Showed no significant difference between the two groups in tibial rotation at knee flexion angles. However, Jin Young O et al. Showed that anterior tibial translation under simulated pivot shift presented better results at low flexion. However, these differences were not significant between the double bundle ACLR and the single bundle ACLR. In short-term follow-up, there was no difference in pivot shift test or objective assessment on the KT1000 arthrometer in the single bundle and double bundle repair. These results were echoed on a 10-year follow-up. However, on a 15-year follow-up, the objective international knee documentation score was significantly different, with a better score being in the double bundle group. The functional outcome knee scores showed no difference with respect to the Lizome score, the IKDC score, the Tegner score, and the KOOS score. At 10-year follow-up, the similar results were echoed, and at 15-year follow-up also, there was no significant difference in the subjective scores with respect to the outcome. Functional outcome with respect to return to sports was 66.7% in double bundle group and 65.2% in single bundle group at 12 months follow-up, which was not statistically significant. It was not statistically significant at 24 months either. The complications, absolute complications with single bundle repair was 7.7% and anatomical double bundle repair were 9.4%. Again, these were not statistically significant. With respect to graft failure, it was 4.3% in the single bundle group and 2.3% in the double bundle group, which was not statistically significant. Complication resulting in osteoarthritis was studied in the medial, lateral, and patellofemoral compartment of the knee, which was again not statistically significant. The current trends in 2021 were shown by Tashman et al., who said that there is no difference between the single bundle or double bundle ACLR when the tibial insertion site is between 14 mm and 18 mm in size, as both grafts are equally effective. However, a study by the ACL study group, which took polls of all the arthroscopic surgeons, suggested that 90% of the respondents performed a single bundle ACLR 90% of the times, while only 7% preferred a double bundle ACL reconstruction. In conclusion, the double bundle ACL reconstruction is comparable to anatomical single bundle ACL reconstruction in terms of the mechanical stability, patient-related outcomes, and complications. The double bundle ACL reconstruction, however, should be avoided in patients with open physis, a narrow femoral notch of less than 12 mm, and a small tibial insertion site of less than 14 mm. These are my references. I thank you for your patient listening, and I thank the Bombay Orthopaedic Society for providing us with this platform. Thank you so much.
So thank you, Mitali. I'll invite the judges for questions.
Congratulations, Mitali, Dr. Nikhil here. It's a nice presentation. Can I ask you just a simple question?
Yes, sir.
In this single bundle or double bundle, what are your graft options?
So in single bundle repair, the graft options can be hamstrings, central quadriceps tendon, bone patella bone tendon graft, or the peroneus longus graft. Whereas in double bundle, semitendinosus and gracilis can be used, hamstring autografts. There are a variety of grafts which are used, but since the topic was to compare single bundle versus double bundle, the graft options were not considered during review.
Okay. Okay.
Mitali, very good presentation.
Thank you, sir.
Question from my side is the incidence of osteoarthritis
Yes,
in
sir.
single bundle versus double bundle. Have they compared with the quality of the quality of sports person, like is a sports person, non-sports person, or is there any concomitant injury of cartilage or meniscus, or they have avoided this and given the results?
So the results were considered in general population with no concomitant injuries at a 5-year follow-up, and radiographs were used to assess the KL staging of osteoarthritis at a 5-year follow-up.
Okay.
Okay, any other questions? Ashish, Darshan? Okay.
I think we are okay.
Yeah. So I think, thank you, Mitali, and that was a great presentation.
Thank
Let's
you, sir.
invite our next contestant.
Sir, am I audible? Hello.
Yeah, you're audible.
Yes,
Yeah,
sir.
you
I'll
can
just
share
share
your
my-
presentation and we can start. Okay, we can see your presentation. Go ahead.
Yes, sir. A very good evening to one and all. Firstly, I would like to thank BOS for giving me this wonderful opportunity. Today, I'll be doing a narrative review on the role of PRP injections in arthroscopic rotator cuff repairs. Few innovations become popular because of their efficacy, and few innovations start to gain popularity because of celebrity status. PRP was first used in 1987 in an open heart surgery, but it was brought to fame in the field of orthopedic sports medicine when the news hit that Tiger Woods had taken 4 PRP injections post his ACL reconstruction, which expedited his return to his golf. Rotator cuff retear continues to remain a challenge. There are various surgical factors like large tear size, massive retraction. The method of repair also influences it. Besides that, increased age, poor cuff quality, smoking, diabetes have an impact on it too. Restoring the cuff function is all about keeping the humeral head in place. If we have a failed rotator cuff repair, there's going to be a superior head migration, which would lead to a rotator cuff arthropathy. So the problem lies in the fact that these large chronic degenerative tears have an inherent decreased microcirculation. When a repair is done, they heal by a fibrovascular scar formation at the tendon bone interface. This is a biomechanically inferior construct, which is a potential cause for these rotator cuff re-tears. In the quest of improving healing, various biological methods have been tried, like PRP, bone marrow, concentrates, mesenchymal stem cells, and patches. But the most commonly used is platelet-rich plasma, and that is going to be the topic of discussion today. PRP is basically autologous anticoagulated blood prepared with a double centrifugation technique. There are 2 types. There's a leukocyte-rich PRP and a platelet-rich PRP, which can be used. So the 4 A's of how PRP can work in cuff healing. There's alpha granulation, which releases growth factors. It stimulates collagen production and improves the tendon strength and integrity. Besides that, there are anti-inflammatory, analgesic, and angiogenetic effects in which the PRP works too. So we searched electronic databases. We did a PubMed search. I did a Google Scholar search, and relevant cross references from these articles were taken. Systematic reviews, meta-analysis, randomized control trials were included, and all articles had a high citation index. We included all cases where arthroscopic rotator cuff repair was done for full thickness tears, Single row as well as double row repairs were included. All studies had a greater than 2 years follow-up. Massive cuff tears, partial cuff tears, revision cases were excluded, and glenohumeral arthritis and fracture dislocation cases were disregarded too. I have divided my literature review into 3 parts, which is efficacy, timing, and cost effectiveness. The groups which are compared were arthroscopic rotator cuff repair with a simultaneous PRP injection versus a pure arthroscopic rotator cuff repair. The early studies in 2014 and 2016 showed that there was no significant difference between the two groups and there was no significant benefit with the PRP injection. However, early meta-analysis in 2015 and 2019 did show that PRP usage had a significantly higher healing, lower retear rates, and better functional outcomes. Coming to the landmark paper in 2022 and 2023, which was the largest meta-analysis done for this comparison, showed that there were lower retear rates, improved post-operative functional outcomes, and reduced pain with the PRP injection. Now we need to understand why there's a conflict of conclusion between the earlier and later studies. The earlier study, this rationale was given by Ahmad et al. In his study, where he said the earlier studies did not have enough number of patients and were not statistically powered to note the difference that the PRP would have on a cuff healing. There are 2 studies which have compared leukocyte-rich PRP and platelet-rich PRP, and platelet-rich PRP is found to be superior to the leukocyte-rich PRP. This probably stems from the fact that leukocytes have an increased catabolic signaling and inflammatory mediators are present in that, and platelets have an increased anabolic signaling. So when we do a cuff repair, there's a lot of hematoma which is formed, which already has a lot of growth factors. Giving a PRP injection at that very time can lead to potential dilution due to excessive growth factors, maybe washout effect due to the saline, and giving a delayed PRP injection can lead to sustained release of growth factors. This hypothesis was given by Wang et al. In his study, but interestingly, when he conducted the study, his outcomes showed no significant difference with a delayed PRP injection. A study in 2021 by Liu et al. Showed that when they compared a day 0 and a day 7 PRP injection versus a day 0 PRP injection post a rotator cuff repair, there was no significant difference with the delayed PRP injection group. 2 studies in 2015 and 2016 have compared the cost effectiveness for it. They showed that PRP is good for reducing retear rates in small to medium sized tears, but it's not cost effective. A few points that I noticed during my literature search was that all these studies had PRP preparation protocols which were different and they lacked standardization. So considering PRPs prepared from the patient's own blood, each PRP will have a different concentration of growth factors, which might confound these results. Differences of cuff tear characteristics in the reviewed articles don't allow us to get a clear indication as to which cuff tear would benefit with the PRP. Also, differences in surgical techniques of the trials reviewed in meta-analysis also were a limitation of my search. So all in all, the take-home message according to me is that efficacy of PRP augmentation is not very conclusive, but recent studies do show promising results with reduction in retear rates, improved pain scores, and improved functional outcomes. Delayed post-operative PRP injection has a theoretical rationale, but the studies prove otherwise. PRP augmentation with cuff repairs is not cost-effective as of today, but more Indian studies and more studies with larger number of patients are required. All in all, we need more RCTs and meta-analysis in the future with larger number of patients, longer follow-ups, to be more certain of the efficacy of PRP injections and to define standard indications where a PRP injection can be used. These are my references. Thank you.
Thank you, Nihar. I'll invite the judges for questions. Dr. Nikhil, you can go ahead.
Nihar, very good presentation. A lot of clarity you have thrown on this topic.
Thank you, sir.
And I just want to ask you, what do you think is or you find in the literature, the common causes for retear of these cuff repairs? Common causes?
In general, sir, or
in general?
So as I mentioned, basically, most of the cuff tears are in these old group, which is 50 to 70. They are basically degenerative. They have a low microcirculation. So what happens is when you do not augment it with any kind of biology, they heal by a
So you mean age is the only factor? Any other factor you feel?
Oh, age, there's
You would
age,
like to consider?
size of the tear, smoking, diabetes. Then there are factors like post-operative protocol. If you start early active motion, there
Okay.
are higher chance of retear rates.
Anything on the MRI you would like to see, particularly that if I see this finding and I would like to add PRP?
So
Anything on the MRI you see?
the cuff quality, maybe we can look at the tangent sign. So if and the fatty infiltration.
Right,
So
right. Fatty infiltration also is one factor.
yes,
Yeah.
got earlier grade 3 or 4 are prone to cuff tears. If there's a reduced muscle bulk, if there's a tangent sign which is positive, probably that will be at a high risk of a retear.
Okay. Okay. Yeah, yeah. Great.
Nihar, a question from my side is, they have compared effect of PRP in a repaired rotator cuff, where we already get growth factors to the tunnels. Have they ever tried in a conservative method, non-operative rotator cuff repairs with PRP? And what were the results?
Yes, sir. So in 2023, there was a study which I came across where they compared, it was the only study where they compared PRP injection so it was a partial cuff tears, a PRP injection only versus a rotator cuff repair where they're taking down the cuff and re-repairing it. So they found that the results were comparable. They had around 80 patients which were taken, which is probably a less number, but they did not find one group inferior to the other. They stated that PRP only PRP injection for partial cuff tears is equivalent to a rotator cuff repair, but this is only for partial tears. And we would logically consider only PRP in partial cuff tears which have failed conservative treatment. Because if it's a full thickness tear, I think we would go for a repair first.
So that's what I mean. If PRP has to work, it should work in a non-operative. They are already exposing the bone mass to the repair.
Sorry, I couldn't hear the last part. Sorry, sir.
Right. The second point was how PRP helps in reducing the pain, analgesia.
Sorry, can you repeat the question, sir?
Effect of PRP in reducing the pain, analgesic effect. You said 4 A's, no?
Yeah. So in basically there is a protease receptor 4 peptide which is stated theoretically that gets released, and because of that there's an analgesic action.
Right.
Okay. Any other questions, Ashish?
Nihar, are there any Indian studies from any of the large high volume centers that are there in India?
Yes, sir. In 2022, Pandey et al. Had conducted a study. He had done a randomized control trial where Pandey et al.
No, I mean which institute?
Manipal.
Yeah, Manipal. Yes, sir. Yes, Manipal. Yes.
Okay.
Yes. So according to Pandey et al., also a PRP augmentation with a rotator cuff repair does lead to lower retear rates and improve functional scores compared to a only PRP in only arthroscopic cuff repair. But it included only small. I think it included only less than 3 centimeter tears, if I'm not mistaken.
Right. And when you reviewed all these papers and these meta-analysis, was there any mention of any conflict of interest or so? I mean, some industry-sponsored trials or some?
There would be in some, but sorry, I didn't.
No, that's fine. That's fine. I'm just out of interest, I was asking because there are different companies which are manufacturing kits for PRP.
Yes.
And now a lot of people are not using industry-driven kits. They're actually manufacturing their own PRP in their own hospitals.
Right. I agree that industry bias might come in. So that's why my conclusion is that we really need more studies to bring it into clinical practice.
Nihar, one small question. What do you think is the most important component of the PRP? Should it be low leukocyte count, or should it be high platelets, or the cytokines? Is there any study which is showing one particular factor is important for cuff specifically?
So there is one study in 2023 which showed that a high platelet concentration of specifically 1 million per microliter is very effective for cuff healing. So you need they use 5 ml of therapy in that study, 1 million platelets per microliter.
Great.
Excellent. Good.
I just have one more question to you, Nihar.
Yes, sir.
Is PRP recommended in any of the standard guidelines right now?
No, sir. There are no standard guidelines for PRP. Absolutely no standard
No,
guidelines.
I'm not saying guidelines for PRP. Saying guidelines for rotator cuff tears, are they recommending use of PRP?
Honestly, in my literature search, I did not come across any specific guidelines. And over the years, whatever I've read, I've never come across PRP. To be honest, it was a new topic for me also.
Okay.
And yeah, so
Okay, good job.
thank you.
So I think we don't have any more questions for Nihar. We can move ahead with Dr. Vasav. Yeah, we can see your presentation. Go in slideshow share mode and we can start. Okay, we can see it. Go ahead, Dr. Vasav.
Yes, sir. Just a minute. I think there's some issue. Am I audible, sir?
Yeah, visible.
Much better.
Hello, everyone. I am Dr. Vasav Somani, currently a fellow in shoulder surgery at Seoul National University, Gundam Hospital. Good evening, everyone. I would like to thank viewers for this opportunity to give us this platform to present. And my topic for today's discussion is meniscus repair versus meniscectomy, a comparative analysis of long-term outcomes. So I'd like to begin my presentation by comparing the meniscus with the suspension system of the car. Just as the car suspension system protects the chassis, the meniscus protects the knee by acting as a shock absorber, and it provides stability and evenly distributes the load across the knee joint and thus imparts longevity to the knee joint. In the study published in Journal of Clinical Biomechanics, this study assessed the impact of meniscectomy on knee biomechanics, where they compared the compression stresses in medial meniscus and the medial articular cartilage across different conditions of the knee, starting from healthy joint to the total meniscectomy. And from the graph, it is clearly visible that the stress level in the medial meniscus and cartilage dramatically increases with each type of meniscectomy, highlighting the crucial role of meniscus in protecting the knee cartilage. Thus, meniscus matters, and hence one should choose wisely for lasting knee function. So my methodology for this literature review has been based on electronic database from the PubMed and Google Scholar with a filter to include the studies relevant in the last 10 years, a reference list of selected articles, and studies with high citation index were chosen for the narrative review. So to begin my presentation, we would like to compare the short-term and the long-term outcomes of the two procedures from the journal Orthopaedic Surgery. This retrospective study from Singapore compared the procedure based on the outcome of Efficacy score and segment activity level score. Based on this graph, we can see that the meniscal repair maintains high functional scores both in short-term and long-term. And whereas meniscectomy, although offers immediate relief in short-term, it is unable to maintain the improved outcomes over a long period of time. Thus, meniscal repair wins for meniscectomy in longevity. Meniscectomy, although it provides immediate relief, but has less durable benefits. In this another study, we would like to compare the long-term outcomes of the two procedures. This systematic review compared the clinical outcomes based on IKDC and lysohome scoring. It compared the radiographic outcomes and the reoperation rates of the two procedures. So, over a period of 10 years, 100% of the meniscal repair patients rated as excellent at long-term follow-up based on the clinical outcomes in comparison to the 54.2% of the patients who underwent partial meniscectomy. And in terms of radiographic outcomes, 78% of the meniscal repaired patients did not show any progression of radiographic changes in comparison to the 63% of the patients who underwent partial meniscectomy. When we take a look at the reoperation rates of the meniscal treatment, the partial meniscectomy shows much lower reoperation rates than meniscal repair over time. The reoperative rates of meniscal repair were 22.4% on an average in comparison to the partial meniscectomy. This study further went into the depth and compared the reoperative rates of medial meniscus and lateral meniscus. And they divided the patients of both the meniscus into three groups. One was partial meniscectomy, other was isolated meniscus repair, and then the meniscus repair with the ACLR reconstruction. In this, over short-term and mid-term outcomes, they showed that the patients who underwent isolated meniscus repair had high reoperation rates, and over long-term follow-up, the patients who underwent meniscectomy had high reoperative rates. In terms of long-term follow-up and meniscectomy, the patient of the lateral meniscus had high reoperative rate, and in terms of isolated meniscus repair, the patients who had medial meniscus repair had high reoperative rates. So, based on this, the meniscal repair wins in terms of functional outcomes and the radiological outcomes, and the meniscectomy in terms of this wins in terms of reoperation rates. Next is the study where we have compared the outcomes of both the procedure in terms of age. This is a retrospective study published in the Journal of European Society of Post-Traumatology and Knee Surgery and Arthroscopy, where we compared the patient-reported outcomes and the failure rates between the two procedures in patients of more than 40 years of age with a follow-up of more than 24 months. And the outcomes were analyzed based on IKDC score, marks activity score, and the patient satisfaction score. Based on this, there is no difference in the patient satisfaction in the two procedures, and the patient-reported outcomes are same for both the procedures. However, the failure rate is high for meniscal repair, and the failure rate is around 17.9%, which is almost in comparison to the failure rate of the younger population who undergo meniscal repair. So the key takeaway of this article is that in a patient age 40 or older, both meniscectomy and meniscal repair is satisfactory patient-reported outcomes, and one should not consider age as a contraindication for meniscal repair. Next, I would like to compare the outcomes for individual tear patterns. So this is a study which did a 10-year comparison of the vertical lesions of the meniscus. It's a 10-year multi-center retrospective study which solely focused on the vertical tears of the meniscus. So they compared the outcomes based on the KOOS score, and in this clearly the meniscal repair provides superior functional outcomes both in terms of failure and aesthetic activity, making it a better choice in a patient with a vertical meniscal tears. And in terms of radiological outcomes, the patient who underwent meniscal repair, 78% of the patient did not show any signs of radiographic progression of arthritis, whereas in a patient who underwent meniscectomy, 64% of the patient had grade 2 OA or higher. Next, I would like to compare the outcomes for the bucket handle tear of the meniscus, and this study compared the outcomes between the two procedures based on subjective noise questionnaire and the objective IKDC score. In this, the key takeaway of this article is that for bucket handle tears, there is no significant advantage in terms of clinical outcomes for either of the methods. However, they divided the meniscal repair in degenerative group and a non-degenerative and a degenerative group. And the patient with the degenerative repair group had lower subjective score, which suggested that there is chances of non-functional healing. Hence, the clinical recommendation from this article is that meniscal repair in degenerative cases may not improve outcomes in comparison to the meniscectomy. Next, we take into the consideration the horizontal cleavage tear. This is a systematic review which compared the outcomes and the complications of surgical treatments of horizontal cleavage tears of meniscus. In this, 67% of the patient underwent meniscectomy and 32% of the patients underwent repair. And the outcomes are in terms of lysohome score and IKDC score are comparable for both the procedures and show similar outcomes. However, the failure rate or the complication rates are higher for the repair group. So the meniscal repair is higher complication and revision rates than meniscectomy for the horizontal cleavage tear, hence highlighting the need for cautious selection of patients for repair, especially in the degenerative tears. Next, I would like to compare the outcomes for the medial meniscus posterior root tears, which is a systematic review and meta-analysis, where almost 57% of the patients with the root tear underwent meniscectomy and 42% of the patient underwent meniscal repair. And the lysohome score for the patient who underwent root repair was almost on an average 30 or higher than the patient who underwent meniscectomy group, and the complication rate was higher in patients who underwent meniscectomy group, and the radiographic progression of osteoarthritis was higher in the patients who underwent meniscectomy. So also here, the meniscal repair provides significantly better outcomes in maintaining knee function and delaying osteoarthritis rather than meniscectomy. Now, we will compare the outcomes of two procedures for the patient with the lateral meniscus tear. So, this study evaluated the outcomes based on the IKDC score and failure rates over time. In this, when they compared the IKDC score, the patients who underwent lateral meniscal repair showed higher IKDC score, and the failure rates, which were analyzed based on the reoperation rate and the symptomatic OI. It showed that the patient who underwent repair also had a higher reoperation rate, but the degree of progression of osteoarthritis was higher for patients who underwent meniscectomy. So, for lateral meniscus tear, it is always better to repair rather than to remove. Next, in order to compare the efficacy of both the procedures in a country like India, which is not having national insurance, we should always take into consideration the cost effectiveness of both the procedures. So, when we compare both the procedures, we see that the meniscal repair, it isn't only better for the knee, but it is better for the wallet too, because on an average, it saves almost $14,700 per patient in comparison to the meniscectomy, and the quality of life for patients underwent meniscal repair was higher by almost 4 extra quality adjusted life years. So it is both for joints and the wallet. This study aimed to evaluate the long-term cost effectiveness of both the procedures associated with each procedure for meniscal tear over a 30-year horizon in a US context. and showed that although the failure rate was higher in patients who underwent meniscal repair, the incidence of osteoarthritis and the TKR was lower in the patient who underwent meniscal repair. The average cost saving was higher in the patient who underwent meniscal repair, and the quality adjusted life year was also higher for patient who underwent meniscal repair. So in this, there are two cricketers, one from the England cricket team and another from the Australian cricket team. This is Andrew Flintoff on the left side, who had a meniscal tear and he underwent meniscectomy. And because of that, we know that he had to take a lot of breaks in his career. On the other side is the Mitchell Stark. He also had a meniscal tear. However, he underwent a meniscal repair, and we can see all the outcomes of these players in the T20 2023. So I would like to conclude my presentation with this, that the tortoise and the rabbit. So the rabbit who started underwent a meniscectomy, if we consider, he started very fast in the race, but however was unable to win the race. However, the tortoise, he started slowly following meniscal repair. However, he won the race because the clinical outcomes for meniscal repair were better. So slow and steady wins the race. Thank you for your time and patiently listening.
Thank you, Vasav. I'll invite the judges for questions. Dr. Nikhil, you can go ahead.
Yeah, congrats, Vasav, for such an exhaustive, detailed explanation of so many papers we have got. I know it's a complex topic, but I think it's comparing apples to oranges. Meniscal repair has their own advantages, and when repair has to be done, it has to be done. And yes, meniscectomy, you have shown that it has good early results and the reoperation rate is less. My question is, when would you consider to do a meniscus repair? What are the criteria?
Criteria, sir, based on my literature review, I would not consider, first of all, age as a criteria. I would consider the chronicity of the tear. I would consider the zone of the tear, whether it's a red zone, red white zone, or a white white zone. For a red zone, I would definitely go for a repair. For a red white zone, I would go for a repair because my aim would be to preserve meniscus rather than do a meniscectomy. And I would rather augment it with some fibrin clots or the BMAC as per the study.
In your articles, I didn't get something about the red-white zone, the zone which is neither on the meniscectomy side, neither on the repair side clearly. So any article saying about the red-white zones?
Sir, actually, I didn't look up the literature in that too, because I decided to conduct my literature based on the tear patterns, age, and that. So I didn't take into consideration the zone-based, because that is why there was no such.
And one, you also mentioned meniscus repair has a high rate of reoperation.
Yes.
So what were the common reasons for this reoperation in your literature search?
For meniscus?
The reoperation after meniscus repair, you said the percentage is higher.
So
it was the reason for these reoperations?
So it was mostly the rate, because based on the clinical symptoms of the patient who had repeated joint flicking following the operation, they did an MRI, and based on that, they concluded that the patient had a ray tear. So ray tear was the most common cause for the reoperation.
Okay.
The result of healing of the meniscus repair, what are the criteria? Is it re-MRI? Patient was again underwent for MRI, or is it a clinical criteria that meniscus is healed?
So most of the articles that I went through mentioned about the clinical criteria as a first line impression. However, they rather had to take up the MRI to confirm the diagnosis, but the first impression they had gotten was based on the clinical symptoms.
Okay, right.
Okay, any other questions? Ashish, you want to ask something?
Yeah, Vasav, good presentation, very exhaustive presentation, and extensive sort of review you have done. So there was a lot of information to take in. So what I wanted to ask is slightly different. You know, when you have reviewed all these papers, have you noticed an improvement in the outcomes with regards to time of our meniscal repairs? I mean, what I want to ask is that papers published in the early 2000s to, let's say, 2015, and over a period of time, are we getting better with our repairs, or our results are just staying the same since the time we started it?
So actually, I didn't go through the literature. I don't exactly remember, but the repair rates are improving and the clinical outcomes are improving. But however, the trends of the surgical trends, for that is the meniscal repair we are doing more and the meniscectomy we are doing less. So it is difficult to compare the outcomes if we compare the two techniques.
Right. So basically, you mean to say we could be getting better, isn't it? That's why we are repairing more and more.
Yeah, because the trends in all the countries, it is improving and going more towards the repair side rather than the exercise in the meniscus.
Okay. So if you have to, I mean, look at all the evidence and sort of, have a checklist for yourself, which is the meniscus which will be a red flag for you to repair? You mentioned that in one of the slides.
Yeah.
You have to just put everything together concisely. Okay, this patient, this type of tear, this zone, bad news for repair.
Horizontal fitness tear or a bucket handle tear with a white zone, maybe in an old age patient.
I think very good presentation here. Good presentation.
Okay. Okay, thanks, Vasav. That was a great presentation. And let's
Thanks
move
for
on
staying
to...
up so late here. I think in Korea it must be what? It must be 2 in the morning. Sorry?
Oh, it's from Korea, yeah.
It's 1:15, sir.
Not too bad. Thanks. Thank you so much.
Thank you. Thank you, Vasav.
So next I'll invite Dr. Dattatreya. You can start sharing your screen and start your presentation.
सीताराम तो अर्थों में आ गया.
Yeah. So we can see your presentation. I mean, you can start.
Just a minute, sir. Yeah. Recurrent shoulder instability involves different modalities of treatment, be it physiotherapy, soft tissue procedures, bony procedures, or a combination of all these procedures. So, can the arthroscopic Latarjet solve recurrent shoulder instability? Good evening, everyone. I am Dr. Dattatreya Sitaram, and the topic that was allotted to me was outcomes of arthroscopic Latarjet procedure for recurrent shoulder dislocation. When we look into the recurrent anterior shoulder instability, it is a disabling problem affecting the young active athletes, and there is a positive correlation with the increased risk of degenerative joint arthritis. But there is little consensus exists regarding the gold standard treatment. The objectives for my review are to evaluate the outcomes of arthroscopic Latarjet in terms of stability, recurrence rates, and complications. And the secondary objectives are to evaluate the surgical time, graft placement, and impact of learning curve and experience with regard to this procedure. Why does instability recur in shoulder dislocation? When we look into the evidence, around 60% of the patients with acute traumatic anterior shoulder dislocation is complicated by recurrent instability, and this risk increases with younger the age and associated lesions and male gender. The conventional treatments for recurrent shoulder dislocations are Bankart and Latarjet, and the principle of Latarjet surgery works on triple block effect, that is increasing the bone cavity, the glenoid tract, muscular sling, and capsular effect. A glimpse into the historical timeline of this procedure. In 1954, Michael Latarjet proposed the surgery, and the arthroscopic version was later proposed by Lafosse in 2007. So here is an image showing the different portals that are required for arthroscopic Latarjet surgery. These are the intraoperative images of the surgery showing the various steps. So to summarize the steps of the arthroscopic Latarjet, first we harvest the coracoid process and prepare the coracoid graft. Then we split the subscapularis muscle and perform the capsulotomy and place this coracoid graft in the anteroinferior glenoid part and fix this graft with the screws. So the search strategy that I followed for this review are by using the keywords of arthroscopic Latarjet, recurrent shoulder dislocation, and outcomes. And the databases that I reviewed are Medline and Google Scholar and publication range. And the studies that included were from level 3 upwards. And the outcomes were divided into 3: clinical, radiological, and functional. Looking into the key findings of all these studies. So this study highlights that 16.7% of patients underwent arthroscopic Latarjet had complications, where one had to convert to open surgery, two had neuropraxia of musculocutaneous nerve, which eventually recovered with physiotherapy alone, and two patients had graft or screw-related problems. And additional surgeries along with arthroscopic Latarjet involved tenodesis of long head of biceps and repair of supraspinatus, slap, and Bankards. As this technique is technically challenging, it comes with its subset of complications like bleeding and hematoma, coracoid non-union and fracture, subscapularis infiltration, and neuropraxia of axillary or musculocutaneous nerve, and excessive limitation of external rotation and arthrosis. So this study highlights that there is a 10% of complications for arthroscopic Latarjet, where 3% intraop and around 7% postoperative complications. So here is a summary of multiple studies highlighting the complications associated with arthroscopic Latarjet, where we can see that recurrent dislocation after this procedure ranges from 0 to 8%. When we look into the radiological outcomes, we should see the graft healing, whether it is united or is there a non-union, and whether the graft is positioned well in both sagittal and coronal planes, and how are the screws, whether the angle is correct, is there any penetration, is there any fracture of the screw or loosening. These are the different modalities that we analyze for the radiological outcomes, and we can see that 15.1% of complications are all related to the screws, be it screw fractures, superior screw loosening, inferior screw loosening, or both screw loosening, etc. And the average angle between the screws and glenoid surface was found to be 28.3 degrees. And in 19.2% of cases, it was found that screws were protruding 5 mm more either anterior or posterior. And when we look into the graft positioning, around 74% of the cases showed ideal positioning, followed by low or medial, and less by lateral and high positioning of the graft. And when we look into the graft fusion rates, it ranges from 87 to 95% of fusion rates. And you can see two studies highlighted here, where in one study there is a 12% risk of non-union, whereas in the other there is a risk of non-union by 2.3%. So now let's compare arthroscopic Latarjet with other procedures, like compare this with open versus arthroscopic Latarjet, where open had a higher risk of nerve damage and the graft malpositioning was higher in open compared to the arthroscopy. However, the surgical time was more in the arthroscopic group. But the open group had a lower rate of persistent apprehension in postoperatively. And here is a systematic review which evaluated the different complications for the shoulder surgeries, where they highlighted that the complications were more in arthroscopic group of 23.7% and 15.3% in the open group. And let's compare the primary Latarjet versus revision Latarjet, where multiple variables were found to be similar, except that there is an increased risk of infection in the revision group. Let's compare the Bankards and Latarjet for the anterior shoulder instability. Overall, the trend suggests and favors Latarjet for greater proportion of patients returning to the sports and throwing activities, as we can see with the functional outcome scores. Now let's look into the learning curve with these procedures. It requires 10 procedures to reduce the need for conversion from arthroscopy to open, and 20 procedures to have similar operating times between the open and arthroscopic group, and 18 to 30 procedures are required for the surgeon and staff to feel safe with these procedures. And after 30 procedures, the complications reduce. So with the learning curve, the surgeon's skill level, the clinical outcome and patient satisfaction increase and complications decrease. And the magic number here is around 30 procedures of arthroscopic Latarjet. Now let's look into the operating time. So here is a study which highlights 5 different surgeons and 5 different setups, and they've tracked the surgical times for this procedure. And in this slide, we can see the summary of multiple studies that looked into the operating time for this procedure. So it just requires 28 cases to reduce the operating time from 183 minutes to 95 minutes for this procedure in the expert's hands. Let's look into the cost effectiveness of this procedure. So as we all know, arthroscopy is more expensive than open, and in this study, they have shown with the evidence that it is 2.8 times more expensive than the open. And is there a cultural bias? Definitely yes. This study highlights that the French surgeons more towards the Latarjet, whereas internationally 90% of surgeons prefer soft tissue Bankart as their initial surgery, whereas in France they would prefer Latarjet over the Bankarts. So few tips and tricks. So it is better to avoid lateral overhanging of the coracoid to prevent the arthritis, and place the screws in the zone of tolerance as shown in the image above. And it is preferred to avoid washers and intra-articular screw placement to avoid the arthritis. And to avoid the fractures, prefer to use narrow drill bits and partially threaded screws and 2 screws sequentially tightened with 2-finger technique. And to avoid the non-union, it is advised to harvest longer piece of coracoid and placed in the lying down position than just the tip of coracoid on the glenoid. And this graft should be placed after decortication of the coracoid as well as glenoid for the better integration. And the screw should be fixed with 2 screws and not single screw, preferably bicortical screws. As there are multiple limitations with the screws, there are advancements in the fixation methods of the graft, where one of which is shown in this image, that is double endo button, where 2 endo buttons are used to securely fix the graft to the glenoid. There are few limitations for this review, as I just followed the single database, and multiple studies showed ROE score, which primarily was only described for Bankarts, but there are multiple revisions. These studies lacked which version of the ROE score was included, and there was no standardization. Example, the position of the coracoid bone block in the Latarjet procedure, or the number of screws or suture anchors in the Bankart repair. So it was not specifically mentioned in few of these studies. Is there any scope for further research? Definitely yes. There is a scope for network meta-analysis in the recurrent shoulder instability, as it involves multiple treatment modalities. So a single study alone cannot include all the treatment options to enoughly conclude which modality is preferred over the other. So there is a need for network meta-analysis. Few points to remember about the graft position. The lateral we place, the more the loss of external rotation and the higher the chances of arthrosis, and the medial or higher we place the graft, there is higher risk of recurrence. So to conclude, arthroscopic Latarjet, the recurrence rates ranges from 0 to 8%, and this procedure has good to excellent outcomes in more than 90% of patients. Arthroscopic Latarjet is a challenging yet viable technique to treat anterior shoulder instability, achieving results equal to open technique with advantages of the arthroscopic setting. The surgeons and staff should be trained to perform the surgery in open technique first and have the knowledge and familiarity with arthroscopic instruments, and the surgery can and should be converted to open at any sign of danger while performing the arthroscopy. So coming back to the first question that we had, can the arthroscopic Latarjet solve recurrent shoulder instability? And the answer is yes, but only in the hands of experienced surgeons and after crossing the learning curve and performed at high volume centers. These are the references that I had followed for this review, and thank you for your time and attention.
Okay, thank you, Dr. Dattatreya. That was a comprehensive presentation, but as per the guideline, these are review of literature topics. So anyways, I'll invite judges for their comments and questions.
Yeah, Dattatreya, very good description about the entire procedure and especially emphasizing on the complications of this procedure. My question to you is, I didn't get a clarity what is the right indication for doing this procedure?
Sir, Latarjet indication would be age less than 20 years, high contact sport individual, and when the surgeon is trained and comfortable with this procedure and he has enough experience with the open Latarjet procedures.
Anything related to the anatomy of the bone, any bone
Yes,
loss?
and when the glenoid bone loss is more than 10%, the Latarjet is indicated. And when the associated lesions, when there are present, like Hill sacks more than 15% of the humeral head, or like external rotation loss more than 85 degrees, then when there are associated lesions, Latarjet is indicated.
Yeah, I think you should go a little bit in depth about the right indication for this procedure in terms of bone loss, and also the concept of on-track, off-track lesions. Just have a look after this presentation. Yeah?
Yes.
They're a nice presentation.
Thank you, sir.
Very crisp presentation. My question to you is, have they compared nerve injury, incidence of nerve injury between the two procedures, arthroscopic and open?
Yes, sir. They have compared the nerve injuries, and they found arthroscopic group had lesser risk of nerve injury compared to open because of the magnification and visualization of the nerve intraoperatively. But again, this finding is not consistent with all the studies. Few studies had higher risk of nerve injury in open, but overall, majority of the studies had higher risk of nerve injury with open compared to the arthroscopy. So arthroscopy had lesser risk of nerve injury, but this nerve injury was found to be neuropraxia only, which recovered with time, and most commonly the axillary or musculocutaneous nerve.
And if they are doing arthroscopic Latarjet, have they added remplissage into it, and what percentage, and what is the criteria for that?
Sir, the associated surgeries showed whether they have performed the associated procedures like remplissage or bank cuts or the tenodesis of the bank cut.
Is there any criteria for that?
Yes, sir.
When to
Regarding
add a
the
remplissage?
exact criteria was not mentioned in the studies that I had reviewed, but I'll look into it, sir.
Okay.
Yeah, Ashish, any questions?
Yeah, I think I missed that point, Dattatreya, when you mentioned. Just tell me, between open and arthroscopic Latarjet, you said that the risk of the apprehension was less in which group?
In the open group, sir.
So open group, the apprehension of dislocation was less. And was there a difference in the risk of redislocation in open versus arthroscopic cohort?
Yes, sir. There is difference between the risk of redislocation and recurrent instability with open versus arthroscopy. But
which one is better?
It is almost similar, sir. Like few studies showed no statistical significance. So that is why they say that it is also an effective procedure to reduce the recurrence.
So it is ineffective, you said, or it is an
effective? Effective. It is an effective.
It is an effective procedure, right? And you also mentioned about the French doing a lot of Latarjet procedures. So now, amongst the French, are they subscribing to the open philosophy, or they are all going the arthroscopic way?
Now there are more and more surgeons adopting the arthroscopic Latarjet. But earlier papers from France were more of open, but now there is a increased adaptation of arthroscopic procedure in that particular region.
But I mean, if it's a more expensive procedure, more learning curve associated, it gives less sort of apprehension. The apprehension is better with open procedure. Then why are we moving to an arthroscopic Latarjet, and why not stick with a standard open Latarjet?
The surgeons who performed that surgery are able to deliver equivalent or sometimes better results in their hands, and so they are proposing the advantages of arthroscopy, being minimally invasive and lesser morbidity, etc. So just like any other surgery where we have open versus arthroscopy, even in this procedure they are trying to increase the surgeon's awareness that this surgery can also yield equally good results compared to the open.
But it is at a much larger, much longer operative time, isn't it?
Yes, sir. But the operating time was almost similar after the 30 cases. So in one slide about the learning curve, I mentioned that After 20 cases, it just requires 20 cases of arthroscopic Latarjet to achieve the time that we take for open Latarjet. So that is what. I may have presented the slides and showed the reference at the bottom, but all those tables that I had included there are tables made by me and not from the articles. So I had summarized multiple papers and I've put up in that. So in the learning curve slide, there are 4 different papers which showed that around 30 cases that it requires to safely.
No, I completely agree. I mean, I'm just asking for my knowledge that, yes, you're taking 30 cases of arthroscopic Latarjet to arrive at a good outcome. But those 30 ones are also the ones which are going to have a very high incidence of complications, isn't it? Because the complication rate you mentioned is much higher in the earlier part of the learning curve.
Yes, sir. So there is one other paper where the pioneers of this surgery were involved in that paper from 5 different settings, and they have analyzed their first 25 cases, and they have divided that into 3 groups. So what they found is, in the last 10 patients, that is from case number 21 to 30, they had no complications. So yes, that is definitely there with any surgery where initial part of the learning curve, the complication rates are higher. But what they're trying to propose is that with expert mentor and performed a couple of times under supervision, this technique definitely can yield equivalent results with as open surgery.
Dattatreya, has there been a case report or some report on vascular complication with this arthroscopy Latarjet?
Yes, sir. In the evidence, there is a mention of neuro as well as vascular. Because yes, so there is safe zone and suicide zone. So the medial to the base of the coracoid, whenever they go while osteotomizing, they can have a risk of injury to the vessels and plexus. So
no, the report, is there been a reported literature on vascular complication?
Yes, sir. There is. I have read it, but exact numbers I'm not able to put it across. But this is what they have described: the safe zone and suicide zone for the coracoid osteotomy while performing Latarjet.
Okay.
Okay. Any other questions?
No, I would comment that, from your presentation, actually, you could even have concluded that, maybe we are not ready for a arthroscopic Latarjet to be advocated for each and every surgeon.
Yes, sir. I had concluded that with a star mark saying only in the expert hands after the learning curve and at high volume centers. So I'm not trying to propose the surgery that everybody has to do. This is just part of the topic that was given to me.
No, well presented. Very well presented. Whoever was available.
Right. Okay, with that, we come to an end of this session. Darshan, are you around?
He might not be there.
Yeah. Okay, then I think all of you presented very, very well and well-researched presentation. I'd like to thank the judges, Dr. Nikhil and Dr. Sandeep. And any other closing comments, Ashish?
No, I think it's been very good, and we will let you know in due course of time how who's selected and what your performance were. I think we had a good session. This videos will be available on Ortho TV. It will be there on YouTube. Even you can sort of refer back to them. You can ask your friends to see them. And I would really want a lot of our BOS members and members all across who are interested in this specialty to watch these videos, because these are very well researched, very well comprehensively presented material, which you would not see otherwise in a conference or in a 6-7 minute presentation.
Thank you, Ashish, and thank you, Dr. Ashok, for inviting us, and thanks, Sandeep, and congratulations to all the presenters. And as Ashish said, definitely it's a very good compilation of so much data, and even we have learned from and so much from this presentation. Thank you, BOS.
Thank you.
Thank you.
We can stop now.
Thank you, sir. Thank you.